Okay, bienvenidos. Welcome to the Serving Latinx Populations in Primary Care Behavioral Health webinar, the first webinar of 2022. So we are very happy to have all of you here. My name is Jaira Oquendo, pronounced she, hers, and I am a Serving Latinx Population task leader along with Natasha Perez Valle. And we are so happy that we are starting the year with this amazing presentation that we're going to talk to you in a minute. I'm just going to post in the chat or link for you to have more information about our group, and feel free to email me, to email Natasha if you would like to have more information about it, especially about our future plans. The big idea is to have a webinar the last week of every month, or a community call. So that's what we're going to be doing. I'm going to post here in the chat also our purpose. So if you have a moment, you can also read it and know that the main purpose is to provide good information to continue serving the Latinx communities that are around us, that we're part of. The next webinar will be February 23rd at 3 p.m. Eastern Time. And it will be very, very good because we will be talking about mentoring Latinx and how to create mentoring spaces for Latinx. This webinar will be recorded and posted somewhere in our CFHA platforms. I'm pretty sure that Liana can clarify any questions about where this will be posted. I'm gonna let Natasha, who is our co-leader, to introduce the presenters. Natasha?
Thank you. Hi, I'm Natasha Perez Valle, and we are excited today to have the Pediatric Physicians Organization at Children's. Before starting, let's learn a little bit about our presenters. We have today with us Jasmine Serrano. She's a community health worker. She's currently completing her bachelor in psychology at Southern New Hampshire University. Her knowledge has provided her with valuable skills utilized to advocate, educate, and connect with individuals positively. She has a passion for giving back to the community and going the extra mile. Also, we have Temitope Osimye. She earned her MPH degree from the Harvard School of Public Health, and she's a certified professional in healthcare quality. She has almost a decade of experience working in quality improvement, especially in the pediatric primary care setting. She also has special interest in optimizing workflows using improvement methodologies, and more recently focused on addressing health disparities and health equity to make healthcare accessible to the most vulnerable populations. Also with us, it's Ileana McKen. She has been the program coordinator resource specialist for the Pediatric Physician Organization at Children's for 3 years. She's currently completing her master's degree in mental health counseling, and she usually works assessing families for social needs, researching available resources, and connecting the families with supports within their communities. And lastly, we have Maria Jesus Arroyo. She earned her master's degree in psychology from the Universidad Complutense of Madrid and has a certificate of advanced studies in marriage and family therapy from Springfield College. She has worked extensively with diverse and underserved communities throughout Western Massachusetts, providing direct care, training, and supervision to interns and clinicians in a variety of settings. She has been since 2018 a behavioral health integration manager with the PPOC's West region, where she has overseen the implementation of integrated care of 11 of the independently owned pediatric primary care practices. These are our presenters, and whenever you are ready, the floor is yours.
Thank you, Natasha. Good morning, afternoon, depending on where you are, your time zone. I'm delighted, and our team is delighted to be here and share our work with you. It's nice to see many familiar faces from CFHA and also the PPOC. And thank you so much for coming and hearing our work. So we already had introductions. This is an agenda. I'm not going to go through the items because we are mindful of the time, just to give room for discussion and questions at the end. Here's our team picks. So we wanted to do an overview of the PPOC. The Pediatric Physicians Organization of Children's is a statewide network of independently owned pediatric practices that are affiliated with Boston Children's Hospital. And the network serves more than 350,000 children and adolescents across the Commonwealth. The PPOC is committed to improving the health and quality of life of all patients in an equitable manner, adhering to Boston Children's Hospital high quality standards and the mission of No Child Left Behind. To fulfill this mission, we work diligently to develop strategies and approaches that address care gaps in the diverse communities we serve. And lastly, this work is possible through the ongoing collaboration among our teams, quality improvement, patient safety, behavioral health integration, medical home, interpreter services, and the regional support team. This is just a table to show that our organization demographics, the patient demographics, is representative of the Massachusetts population, with a 12% of what is here represented as Hispanic, Latino, and that you are referring to today as Latinx. We will say something about that too later on too. Wanted to mention the Surgeon General Advisory on protecting youth mental health, after the several organizations this year declare a mental health emergency for children and adolescents. So in this declaration, in this report, racial and ethnic minority youth, as well as youth in immigrant households, are among the categories mentioned as a higher risk of mental health challenges during the pandemic. Among the Surgeon Regional recommendations also is building multidisciplinary teams to implement services that are tailored to the needs of children and families. Of course, among this is recognizing the variety of cultural and other aspects shaping the lives of children and families, and the need to provide culturally appropriate, including multiple languages, services to these populations. Here is a link to the full report for those of you who want to deep dive in it. It's fantastic and has many recommendations for organizations, families, and even the youth. I'm gonna pass it on to my colleague, Temitope Osiniji, for an overview of the interpreter services.
Thank you. Good afternoon, everyone. My name is Tope Osiniji. I'm a senior practice consultant with the PPOC. Thank you for the opportunity to present the work of PPOC Interpreter Service and CLASS projects. So I'll start by defining CLASS. So CLASS is an acronym that stands for Culturally and Linguistically Appropriate Services. The Department of Health and Human Services defines it as a way to improve the quality of service provided to all individuals, ultimately with the aim of reducing health equity, reducing health disparities, and achieving health equity. CLASS generally is national standards for CLASS is a blueprint of 15 action steps that healthcare organizations can take to achieve health equity. And I can summarize CLASS basically in 2 words: respect and responsiveness. So we respect the whole individual, in this case, our patients and their families, and respond to their health needs and their preferences. So the CLASS team was put together at the start of last year, January 2021, and ultimately tasked with the goals that are identified there on your screen. It's a multidisciplinary group of PPOC staff bringing in their various experiences from their various teams, including quality improvement, technology, IT team, patient safety, and behavioral health services. So the first goal was to improve access to language services through the Interpreter Service Project. And this actually had been in the works for about a year prior to the start of the class project. So the PPOC rolled out a language service that made interpreter service available to all 500 MDs, NPs, integrated behavioral health providers, and practice staff in all of the over 100 locations of our practice in Massachusetts. So we had a single vendor providing those services to all practices. And as a result of the success of that program, it's evolved into the class project. And some of the tasks, the goals that were given, assigned to the class team, is to look at how we could improve on patient demographic data collection, provide educational materials and resources to our providers and practice staff, as well as make recommendations for culturally and linguistically appropriate services across the network. Next slide. Okay, so I referenced patient demographics in the previous slide, and these are the main data points that we chose to focus on. We realized as a team that in order to respond to the needs of our patients and their families, we had to first have a good understanding, of the population that we're serving. So we chose to focus on race, ethnicity, and language, and as well as some data points around hearing and visual impairment and cognitive needs. This was a result of the newly implemented program of patient-centered medical home. We were transitioning to the NCQA program, and we needed those data points too. But basically, this were the data about our patients that we reviewed in our electronic medical record, EPIC, and we thought needed some changes needed to be made to them. Next slide. Thank you. So these are the different fields in our medical record, as well as some of the response options in the middle column. I'll be focusing on preferred language and race for this presentation. So based on utilization data from our interpreter service vendor, we realized that some languages were being requested for an interpreter was being requested for those languages, but we didn't really have a way to capture those languages in EPIC. We didn't have those fields. So obviously we needed those represented, and the languages that were missing were Brazilian, Portuguese, Cantonese, and others up to Mandarin there on the screen. With regards to race, a new category was proposed based on our research findings. We realized that the US Census Bureau had made some recommendation for including a category for Middle Eastern and North African. And also studies show that people of this extraction would use that checkbox if it's available. And by so doing, we'll be able to capture better quality data to address the needs of this population. So we made a recommendation for that too. Next slide. Thank you. For the purpose of this presentation, and since we're focusing on Spanish speaking population, we thought to be interesting to share our work around ethnicity. So ethnicity, the question we train our practice staff to ask is, do you, as a patient, do you consider yourself Hispanic or Latino? The options we had available at the time in EPIC were 4, decline to answer, Hispanic or Latino, not Hispanic or unknown. We came up with 2 recommendations. First option was to go along with the recommendation of the US Census Bureau. And basically, the emphasis was on breaking down the Hispanic Latino category into subgroups, so Mexican, Puerto Rican, Cuban. And then we also found out, as part of our studies, like Maria alluded to earlier on, there was some movement, to include the term Latinx as a substitute for Latino or Latina. However, studies conducted by the Pew Research shows that only 4% of people that were surveyed actually had a preference for the term Latinx. So looking at our patient population, we thought at this point, we did not want to push for that change yet. We thought to keep the terms Latino as our preferred term. For the second option, this is based on recommendations from the Office of Management and Budgets, which manages this type of data on national level, as well as the Institute of Medicine. Their recommendation was simple: just have a response for yes or no. Yes, Hispanic, Latino, Spanish origin, or no. And they also placed emphasis on defining those terms. A Latino would be someone of Cuban, Mexican, Puerto Rican, South, or some Central American origin, or Spanish culture or origin, regardless of culture. So both options were presented to our PPOC, Patient Clinical Quality and Patient Safety Committee. This committee is made up of representation of providers from all our different practices. And a vote was presented before them, and they voted to adopt option two. Option two got a yes vote, and that option is what we currently use in our electronic medical record system. Next slide, please. Also wanted to talk a little bit about the Hispanic Latino distribution in Massachusetts, since that would kind of reflect on the population of patients that we also serve. So currently it's estimated that we have about 850,000 Latinos in Massachusetts, which represents about 12% of the state population. The largest group nationally of Latinos are Mexicans, but in Massachusetts, the largest group is Puerto Ricans, followed by Dominicans. And we have the highest concentration of Latinos, actually highest count by number in Boston. About 130,000 Latinos live in Boston, representing 20% of the city population. But when we talk of the highest concentration in percentage of city population, the highest concentrations are found in Lawrence, Chelsea, Holyoke, Springfield, and Lynn. Next slide, please. So you might be wondering, so what changes, what outcomes have we had so far since implementing those changes around patient demographics? The first table on your screen looks at patient preferred language. Here, patients and families are asked, in what language would you feel most comfortable speaking with your doctor or nurse? And keeping an eye on the last two columns where we have no language entered, we can see that the unique count of patients who had visits in the last 18 months, as at March 2021, we had 6,200 plus patients who did not have any language documentation entered. But by the end of last year, just within a few months of implementing those changes, right around September of last year, there had been a big decline. Now we only have 3,000, a little over 3,000 patient count with no language documentation entered. That still represents a large group of patients, we know, but it's been a good improvement from where we were prior to the start of the project. The second table addresses interpreter needs documentation, and patients are simply asked, would you need an interpreter for your preferred language for this visit? And again, the last column shows an improvement from back in March, where we had over 28,000 patient counts who had no interpreter data entered. That number dropped to about half, by 50%, by the end of last year. And we currently have about 13,500 plus patients that we still need to have the data entered for. So the numbers are going in the right trend. We know there's still a lot of work to do, but I believe we've accomplished a lot within a short period. Next slide, please. And here you're looking at the utilization data for our interpreter service. And the Spanish language by far is the most requested language at about 47%, followed by Brazilian Portuguese. In fact, the top two languages represent over 75% of language interpreter requests in our network. So we continue to work with our vendor to beef up support and resources for providing interpreter services for both languages and, of course, other languages too. Next slide, please. Okay, so this is my last slide. Just to recap that the work we've done so far and what we still have left to do. So around health equity and disparities data collection. We've been able to get approval and implement our recommendations for changes to demographic fields. With over a year of implementing the interpreter service, we continue to experience increased utilization of the service. Every quarter, there's a 25% quarterly increase in requests for services. We've provided education materials and training to our providers across the network, including user guides and step-by-step training videos. For patient resources, we've also provided informational handouts, and these were translated to the top 10 requested languages that patients prefer to communicate with their providers. So currently, the next step in our work is to identify areas where we have disparities in healthcare across our patient population, whether along ethnicity, racial lines, or their insurance coverage. And then we'll also develop interventions to address those areas of disparities. So thank you. And at this point, I'll be passing it along to my colleague. Yeah.
Good afternoon. Per the introduction, my name is Ileana McKen. I am the program coordinator and resource specialist for the PPOC regional support team. Next slide, please. And I have to say it's a pleasure to be part of this collaboration. So just to give you an overview of what we do at the PPOC regional support team, the PPOC regional support team is a team of community health workers and a regional support specialist such as myself who provide telephonic and in-person support to PPOC patients and families who have socioeconomic, medical, and care coordination needs. Our team is divided into 3 geographic regions, which allows us to provide services to patients and practices throughout the entire state of Massachusetts. Currently, our regions are divided into North, South, and West, and collectively, we can cover the entire state, as I mentioned previously. All our referrals are initiated by a PPOC provider or a practice staff member after completing a health needs assessment. I'll talk a little bit about that in a few minutes. And the families are handed over, are given the health needs assessment for completion at time of either during the well-child visit check, or if they haven't been in the practice for a while, we might update it during another time. Maria, next slide, please. So just to give you a visual of what a health needs assessment looks like. So we have this tool in different languages. We also have it electronically embedded in the patient's EPIC system, in our medical record keeping system. And this is the English here and the Spanish. This is a document adapted from the Health Leads recommendation tool. So Maria, next slide, please. So what is the level of support that we at the PPOC regional support team provide? So currently we have the care coordination. Care coordination basically involves telephonic support for practices and staff, not direct patient contact. Basically, I will just give the medical home care coordinator or any practice staff just advice or answer any questions they may have regarding a family. The next level is telephonic resource support. This is where I will actually do all that I do with the care coordination, or also contact the family and process with them, do an evaluation, confirm the needs, identifying the health needs assessment, and provide recommendations to the family via telephonic, emails, or also guide them and help them apply to these different resources online. And the third level of support is the complex care support. This is telephonic as well. But it also includes in-home support or referrals to other agencies that we collaborate with. I do this myself sometimes, but also I escalate this to the community health workers for home visits if a home visit is necessary. Our referrals come to us in 3 different ways, either to the EPIC, which is our medical record system, as I mentioned earlier. We have a message sent to us via that way. We also can, the practices can also do it over the phone or send us an email. Usually the phone calls are more when there's an urgent need and they need us to do those, because usually we have 24 hours or a business day to respond to this call or the referral. Our office that we never close. So that's the one thing, we never close. We do go home for the weekend, but the lines are always open. Some of us are on the line all the time to just make sure that if, especially with the pandemic, if there's a need, that we are able to capture that and assist the families on time. When sending referrals, we ask our practices to provide the information here in this yellow box. Basically, you know, who's making the referral, how to contact the person that's making the referral, the name of the practice, the reason for referral, as well as the patient's demographic information. Next slide, please. So some of the reasons for referral, so that you have an idea. So socioeconomic needs under that category, we do housing. You know, with the pandemic, a lot of people were displaced from their homes. So, you know, we help families with evictions, with notice of to vacate their apartments, food insecurities, either connecting them with resources in their communities or helping them apply for state agency that provides this support. There's also utilities, childcare. The childcare, because the PPOC, we are not limited. We cover all families regardless of health insurance. So we see the childcare need more often when families have private insurance and have high deductibles or co-payments and have a hard time meeting those co-payments. So we help them brainstorm other ways to pay for those services and assist them with those application process. Childcare is a big one. And, you know, right now with the pandemic, as we know, all this socioeconomic needs were very present in our group. And so childcare right now, you know, we connect them with either childcare agencies or someone who can provide that support. Medical needs, at the PPOC, we have the asthma management team. Jasmine will speak a little bit on that in a few minutes. That is a specific area of our team that we work on that area. There's also a specialist visit coordination for families who have too many visits to the hospital and don't have a mean or don't know how to make those appointments. So we assist with that, as well as with medication, access to medication, and durable equipment through DME. So referral for the last reason for referral is external programs. So here we collaborate at the PPOC, we collaborate with Tufts Health Plan care management team. This is a program that usually is only for patients who have the Mass of Tufts ACO program. And they address and support families with transition of care, whether it's behavioral health or medical. And we also refer families that we identify can use that support to them. The next external supporter of ours is long-term service and support. Most of you know the LTSS team. The community partners, we collaborate with them. They assist families on a more long-term basis. So our team usually, at my level of support, which is a telephone, before not the all but the complex care, I assist families usually between 1 day and a week. And once after that week, I transfer or escalate it over to more complex care support, where it'll go to one of the community health workers or be referred out to one of the agencies. So this is when we solicit the support from LTSS. And then finally, the mental health advocacy program for kids. This is a program funded by Mass Health that we are partnering with that focuses on assisting families of children or adults in transition who have a mental health diagnosis and are having difficulty accessing care in their community. That is my role, and that's what we do in a snapshot. I will pass it on to Jasmine, my colleague, for the portion of her presentation. Thank you.
Good afternoon, everyone. Thank you so much for having us. So I am a community health worker in the regional support team at PPOC. Next slide. So the regional support team, like Ileana stated, I get the more complex care cases. So the regional support team kind of focuses more on telephonic in-home support for patients with complex medical or social economical needs. There has been a few program adaptations, such as suspending in-home visits as of March 16, 2020. We've had to utilize Zoom technology to conduct home visits. So during those visits, we'll do health needs assessments when needed, help families apply for benefits such as SNAP, unemployment, fuel assistance, RAFT. We help families with issues around obtaining medications or prescriptions. We help families that are having housing issues, such as potential eviction or needing assistance for shelter placement. During the pandemic, we've had to spice up our little interviewing techniques to substitute for eyes and nose in the home. Supplies and materials are also dropped off. At times of the visits, families will say that they need assistance with getting formula, food and diapers, and we will provide support in that area too. We conduct follow-ups with the practices and also outside resources as needed. We make sure that we connect with any programs out in the area as frequently as possible to make sure that the information that we are providing to the clients is accurate and most recent. Next slide. As Ileana mentioned, we have the medical home asthma program. The medical home asthma program focuses on helping families better manage their child's asthma, stop their asthma from getting worse, and improve their overall quality of life. This is a free program that community health workers like myself make series of visits, now virtually. During those visits, we provide asthma education that helps with teaching the families how to use the medication properly. We teach the family how to read the asthma action plan that is implemented by their PCP. We create an asthma-friendly home by identifying and removing asthma triggers. During those visits, we provide various items such as HEPA filter vacuums, pest management kits, mattress encasings, or dust mites products that can help as well. Next slide. This is a flyer that we provide to the families to have them understand a little bit how the program works. We conduct 3 visits. The first one is a little bit more intense. It takes about an hour where we're going over the medication, asthma action plan, some of the triggers in the home. The second visit, we discuss what are some of the things that they have changed in the home. Let's say not using harsh chemicals anymore, using a vacuum when needed instead of using a broom to sweep, changing the linen frequently. And after those visits, we will stop doing them and then do a 6-month follow-up call just to see where the family is at and how comfortable they are with managing the patient's asthma. In some of these cases, families do relocate, move to other homes, or let's say last visit was in the summer and they're like, oh, can you call us in the winter? Patients' asthma tend to get worse or improve during those times. So we just provide this follow-up call just to see where the patient's asthma is at. If the patient's asthma is not well controlled, we will conduct multiple appointments after that. We can do 4, even to 7, depending on the patient and family's needs. We provide this in multiple languages. And if the family feels that at the moment they don't want to continue receiving the services, we can pause it and continue off in 2 months or another month if they feel like at the moment it's not something that they need because the patient's asthma has been well. I thank you so much for having me. Next slide. And I will be changing it off to choose.
Okay, thank you, Jasmine. So we have a behavioral health integration program in the PPOC that supports the practices with implementing an integration model that is sustainable with evidence-based strategies and behavioral health services embedded in the pediatric medical home. So to create and support a more capable medical home team, we address foundational issues in the 3 following ways. The first one is delivering education to the primary care providers and their teams to improve the management of behavioral health. The second is supporting the integration of behavioral health clinicians into the medical home and implementing integrated care processes. So we support them through that implementation. And the third is providing consultation from behavioral health specialists in the team, like myself, on also affiliated work of psychiatrists and substance use specialists from the hospital. This is just to illustrate the growth of the program from 2013 to 2021, not only in the number of practices that have enrolled in the program, but the number of practices that have hired a behavioral health clinician already. Those are 48, the number of practices with behavioral health clinicians, and the number of behavioral health clinicians in those practices is 101. So some of the practices have more than one clinician embedded. This is data we have from the pandemic on the visits, the behavioral health visits at the practices. The black line is all the visits, the green one is visits in person, and the yellow one is the telehealth visits. We wanted to mention that moving to telehealth was something really important for the organization in terms of keeping the access open for all patients, especially for behavioral health that, as we said at the beginning, were and have been and continue to be at risk for increased mental health problems during this time. So how do we collaborate with the regional support team? The pathway for collaboration starts at the practice in which a behavioral health need is identified or a social determinant need is identified. So we at the PPOC practices administer behavioral health, developmental, and social determinants screenings at every well-child visit, like my team was describing with the health needs assessment. And when a need is identified, the PCP and the team have an option to either do one handoff or a referral to the behavioral health clinician in the case of a mental health concern, or to the regional support team if there is a social determinant. So our team, through the role that I fulfill and my colleagues in the same role, we support the RST with availability for behavioral health consultants as consultations as needed, also participating in multidisciplinary case reviews with the regional support team, as well as fostering collaborations with the integrated behavioral health clinicians in the practices. And also we promote culturally responsible and whole person care. And the way we do this is supporting practices, take patients and family beliefs, values, culture, language, and preferences into consideration, but also incorporating this relevant content in our educational activities with practices. This is just a slide with adapted content from the core competencies for behavioral health providers working in primary care that you probably all in the call are familiar with, just to bring attention to how to engage in culturally responsible conversations with patients and families. For the sake of time, I'm gonna just not go through all of this, but you can see that not only social determinants, but also not making assumptions about the culture of a patient, better to ask than to assume, using the patient language to discuss their health. Obviously, this is connected to the open notes movement as well, in which patients now access their notes, and that has shaped the way we express our clinical opinions in the notes as well. Focusing on cultural strengths, this also connects to the use of cultural brokers if you have some in your communities. And then practices routines transparent to the patient. Talk to the patient about the patient as if the patient were present, and if possible, have conversations directly with the patient in the room. So now we are going to be going through a couple of examples that Ileana and Jasmine are going to speak to about cases that they have had work with in the PPOC.
Thank you. So the first case that I wanted to present was of a 4-year-old Latina little girl of a family of 3, mother and patient, lived with a maternal grandfather. The reason for the referral was because the MHCC was requesting assistance with teaching the family how to use asthma medication because the patient was having a lot of emergency room visits. During the home visit, there was a health need assessment that was conducted, and housing came up as one of the positives because mom wanted to move due to illegal activity in the apartment building. Utilities and safety came positive as well because heat was controlled by the landlord and mom was heating with a gas stove. Safety as well came out positive due to a person being shot outside of the family's door. support as well, because mom wanted a therapist for the daughter due to the witnessing of the shooting. Understanding of the health also came out positive because mom was not sure how to administer the patient's medication properly and missed school and work because she was having uncontrolled asthma. The outcome of some of these were housing was family was able to relocate to a new apartment by completing a letter and submitting it to their landlord and expressing their concerns and how they felt unsafe and wanted to start fresh. Utilities, mom was able to control the heating in her new apartment. The safety in the home, mom was able to write the letter to relocate due to the shooting that occurred. Patient now has an in-home therapist and that is helping with the trauma, stress, and fear that was unresolved. Mom now understands the patient's health as she is able to manage it more, and there hasn't been any ED visits since we last seen her. And patients' days of school being missed have decreased significantly. Since the referral, mom is less stressed, feels safe in the home, confident in managing patients' asthma, and is playful, energetic, and happy. The next case is Ileana that she will be presenting.
So this next case is of a patient. He's 18 years old male, family of 3, mother, older brother, history of developmental and mental health conditions. The referral reason, practice, I was requesting support with access to behavioral health care and obtaining guardianship. The practice and not being successful at connecting resources. This is a case that took collaboration. Some of our cases is, as I say, I do telephonic support, a simple phone call and processing. Some of us require the entire team support to be able to get that family up and ready. So in this particular case, we collaborated with the behavioral health support team as well as the rest of the community health workers. So for the BH support, we were able to, the patient needed a prescriber, we were able to connect this patient with a prescriber as well as a therapist to manage their medication and continue with the visits. Food insufficiencies. We were able to assist the family with connecting them to local resources in the community and also state level food resources. Transportation, we were able to get, there's transportation funded by Mass Health, which is listed here. So they were able to fund that, and the school is providing transportation for this child to get to and from school. Guardianship, so this case still a working process. This is one of my most recent cases. I'm still working on some of the things. So, since the referral, we continue to provide ongoing support and resources. We continue to collaborate as a team, both the regional support. So basically there's telephonic support going on, the care coordination, there's also behavioral health component to this, just to give you an idea of how it all comes together. As we work to make sure that we make our families better and to every child as well. With that said, I want to thank you for the opportunity of allowing us to present in front of you the great work that goes behind the scenes and within our group. And we want to open it to the rest, close out the conversation and open it for questions, for anyone who has questions for us. Thank you.
Thank all of you for being the presenters for our SLIP webinar. Let's see if we have some questions from the audience. You can unmute yourself or you can write in the chat.
I think Lisa put a comment on the chat.
Yes, it says that every child and family should have access to this kind of support. Agree. Hamali, I see another comment here. Wow, the collaboration and integration of your work is evident. This is awesome. Thank you all.
Thank you.
Hi, I had a question. This is Maria from Idaho. So my question was in regards to the education. I think they spoke about education given in regards to either like how to screen for racial questions or things like that. So I just wonder, is education given to like customer service representatives, to nursing, to providers? What kind of education is given?
I think I'll take that question. That's for me. So in terms of education, what we did as a class team was to collaborate with Boston Children's Hospital, looking at the work they had around patient demographics and also educational materials that were being provided to patients. We also did research at best practices that were out there, especially at nationally recognized hospitals. And so we provided like printed materials for staff, first of all, focused on training staff on how to ask the questions. So for around like ethnicity, we're told, given the language, to ask specifically. So you'd ask the patient, would you consider yourself Hispanic, Latino, or of Spanish origin? Then race, the question, that we're trained to ask the patient is, what race best describes, what race would you identify with? What race best describes you? Language was a preferred language to communicate with your provider or doctor. So we provided the exact language that we thought was best and would not be ambiguous when asking patients and families these questions. We had a training video, we had a webinar that was produced on demand, and actually had a role play where we had some members of the team act as patient family, and the other person was a front desk staff, at intake during the check-in registration of families. And the reason why we had a role play was to kind of demonstrate some of those scenarios that would play out in the practice, like if families showed some hesitancy, how would you address those situations? If they asked questions or like clarifying questions, how would they best define the terms that patient are being asked? So those were additional materials that were provided. And then we also developed patient-facing resources. So in the patient-facing resources, we addressed frequently asked questions like, why are you asking about my race and ethnicity? Is this for immigration purpose? Who will be using the data? So we provided some answers that would help the practice, the providers and staff in the practice to respond to patients and families, and clarify that the data will be used within the hospital, within the clinics, and within healthcare organizations and systems to provide the best care that is possible for their patients and their families. Basically, yeah, and then all the resources were made available on a member website so that on demand, practices can go ahead, log in and, review the training materials, the printed materials. And for the patient-facing resources, like I said earlier, we actually had those translated to the top 10 requested languages, including Spanish, so that families who had patients who have limited English proficiency would be able to, read those materials in their preferred language.
Thank you.
Thank you.
Thank you so much for the question. Any other questions from the audience? Comments that you would like to share as well? Feel free to unmute and or post it in the chat as well. Anna is saying the work that you have done is wonderful. Thank you so much for sharing your work.
Thank you all for the nice comments and compliments that you are giving us through the chat. We really appreciate it. Is anyone doing a similar line of work that you guys want to share with us? We're not having a more much activity. I wonder, Jaira, does anyone want to see the specific questions of the health needs assessment or anything like that that we might have rushed through thinking that we will have more questions?
Of course, we can do that.
Let me see if I can reshare.
While you're pulling that up, can I go ahead and ask a question?
Sure.
Yes.
Actually, two questions. One, I'm just curious how you communicate back to the PCPs, whether that's are your is that going back into Epic as a chart note or a log note or something where the PCP who referred is able to go back and see what the community health worker has done or what the care coordination efforts have been? And then I'm also just curious, until we get to value-based payment, how it's funded, all of the work of the care coordinator and the community health workers.
I can respond to the communication back and forth, the turnaround time. So we do put the information in the Epic record system. We do document in the chart. And but if we need something more urgent, we also are, once the clinicians refer to us, they know that, if we have something urgent. So if we need a letter from them for housing to get a family into shelter right away, we call them and or email them in Epic, call us, they'll get that right back to us. But all the feedback, all the communication, we track it in Epic. We put it in Epic for them to see. But within our team, we have RecCap, which is where we keep every contact that we have with the family. We document the date and time because, as I mentioned earlier, once I get that referral to me, the first time I have 24 hours to contact, and we track that. We follow that data and record that data for, to measure our progress. So that's every time, any conversation, any contact, as well as, the conversation, and making sure that in the patient's record, we include that communication. In terms of how the payments are funded or how we get paid, I don't have the answer to that question. I wonder if someone here might. Tope, maybe one of the quality consultants.
I can speak to funding for interpreter service projects that is state funded at no cost to our practices, using funds from the district program. District stands for Delivery System Reform Incentive Payments. And these are kind of new programs that provide supplemental payments to hospitals or providers for taking care of, for providing work that transform the healthcare system delivery. So yeah, district dollars fund our interpreter service projects.
And regarding the care coordination in the practice, so our teams are PPOC teams. The care coordinators are employees by the practices. However, they receive a salary support amount that is correlates with the volume of mass health patients that the practice has. But I cannot specifically tell you, how is the mechanism that makes that happen, but that's how it goes. As for the behavioral health, yeah, go ahead.
Oh, no, I was going to chime in. Sorry, Maria, you're right on track. I got clarification that funding for the regional support team and the behavioral health program is also supported through district dollars.
Yeah. And the behavioral health clinicians get year of salary support available contingent to the billing that they are starting to generate. So in other words, if they meet their salaries and rest of the things that are considered into the position, they don't receive the salary support that month. So we work it like that for 12 months when the support ends, because as I was saying at the beginning, our goal is to make it sustainable, but we want to support them. So that allows them to create a good program without the whole pressure on the sustainability laying only on the hands of the billing done by the behavioral health clinician. And given your question, I assume you are a clinician, a behavioral health clinician, and you're wondering how does that happen. We have a mix of collocation and integration in our practices. Some are fully collocated, some are fully integrated, and some are hybrid, which the literature says is a complicated thing to achieve, but we have some practices that are really functioning well as such, with the billing that insurances at this moment allow, before, as you said, we move to payment per value. Here's the health needs assessment questions for those of you who are interested in knowing what social determinants are explored in the form.
This is fantastic and a great tool. Thank you so much for sharing it. And I do agree with Daniel, who says that wonderful presentation and such essential work.
Thank you. I just want also to say that the work you guys are doing in the CFHA organization is fantastic, and we are very happy to contribute to that in any way, anytime. So thank you for having us.
Thank you so much for the invitation to present to us and start this year with your topic, which was very interesting. And as I mentioned in the chat before, we will continue trying to provide you a community call or a webinar every month at the last week of every month. So stay tuned and check the website and everything.
Sorry about that. If you want to get a hold of the health needs assessment, just get in touch. We can share that with anyone who's interested in having it and using it.
I think that would be good if you can post your contact information in the chat. That way people can get it.
You can find me also as a contact in the organization if you want to message me through that. So
that's fantastic.
All right, guys, thank you so much.
Thank you, everybody. Have a fantastic day.
Thank you.
Thank you.
Thank you, everyone.
Thank you for everyone joining today.